So next topic is carotid IMT, relevance to clinical practice. Again, no disclosures as to financial interests or relationships at this point. Atherosclerosis, a perspective on atherosclerosis. What can we use to measure the presence of a disease which is responsible for 50% of our overall mortality? I mean, that's the real clinical question and the clinical relevance that we have to consider. If you consider atherosclerosis to be a disease of old age, you're completely wrong. Everybody in this room has got it, period. No one is free. Everybody's got it. I don't care if you're 20 years old, 15 years old, or 80. You got it. The normal history of atherosclerosis starts in the abdominal aorta. Thoracic lags a little bit. Coronaries and carotids get it about the same time. And supposedly lower extremity arteries and upper extremity arteries lag a little bit. They lag clinically. They still have atherosclerotic changes. They're just not that clinically important until later on. Now, I had to blind you as to the true identity of these individuals. I'm sure that it worked very well. Two of them are comedians. One had an important political position. I could have put a fourth one in, the guy who got the pump recently. What do they have in common? At the relatively young age, they had coronary artery events, okay? Now, you would think that these people that are relatively important in our society, we would have figured out that they were going to get into trouble. We didn't. The question is, did we have the right tools? Where was the failure? Well, it has to do with the disease process itself. If you look at what's called a P-Day study, and on the bottom are there are diagrams to show the percentage of the area of an artery that has early atherosclerotic changes. And I guess I exaggerated by saying people from 15 to 19 have significant changes. You have to wait till you're 20, at least in this study. In some studies, by the way, in young patients that have elevated cholesterol levels, hypercholesterolemia or hyperlipidemia, you can get early atherosclerotic changes in their teens. That's been described. As you get older, past the 20s, the 30s, you can see that the proportion of the artery wall that has early atherosclerotic changes increases. Now, the true issue is this. Do you want to be someone like this in your 30s, or do you want to be someone like this? And the question is, can we detect it early, and is there a way to give medication to kind of prevent it? One of the strategies out there is using carotid artery intima media thickness, or IMT. So the true definition was coined in 1986 in a paper published in Circulation by Pignoni et al., and it really has to do with ultrasound imaging of the abdominal aorta. That was the first description. They also looked at the carotids. And what they were looking at is basically the distance between the lumen intima interface and the media adventitia interface. Now, there's a big difference in atherosclerosis as to what we call early atherosclerosis of the artery wall and IMT. First of all, this is atherosclerosis in an artery wall. It's involvement of the intima, everything outside the internal elastic lamina or membrane, okay? What we see with ultrasound is actually the distance from the lumen to the external lamina. That's where the external elastic lamina, because that's the ultrasound. That's where the ultrasound we can actually see. Now, it is true if this gets really thick, you can start to visualize it, but mostly what we're seeing is this full distance, okay? So it includes what's in the intima and the subintima as well as what's in the media. But it's still a very robust measurement. Now, atherosclerosis, what you and I look for, and what we talked about this morning when we do our case reviews, clinically we're talking about focal plaque. But this is being interpreted as being another measurement of a more diffuse process that involves the artery wall. Now, what are the interfaces? Well, this is a sample of a human aorta that I basically took, mounted in a piece of plexiglass, and took ultrasound images. And the intima media interfaces that are used to measure the intima media thickness are drawn here between the lines that are green and orange. Now, one of the interesting aspects about the imaging, at least for this imaging device, is I want you to appreciate that the near wall here is kind of blurry. And what a lot of people do not talk about when they talk about intermediate thickness is the performance of the ultrasound machine. And you have to have good near-field detail resolution, something that not all ultrasound probes do in order to do the measurements as precisely as possible. Now, there's a reason why people say you cannot do IMT measurement, and I want you to remember these two numbers. The resolution of the systems that you're using now can go down to 0.1 to 0.2 millimeters, okay? So, in theory, if you believe in the word resolution, you cannot measure anything below 0.1 to 0.2 millimeters, according to Basic Physics 101. Here's an RV wall that's pulsating, and the change in the far wall is about 0.03 millimeters. My question to you is, can you see it? You see the difference in the thickness? If you look very carefully, you'll see that there's a difference in the thickness during that cardiac cycle. You're seeing it. The question is, how come you can see it? You're not supposed to. This is way below 0.1 or 0.2 millimeters. It's about 0.04, 0.03 millimeters. So this is a question of what are we looking at? Okay. Second thing is, you and I are used to image with Doppler. And with Doppler, you want your angle. You want a Doppler insonation. This is what you would get, and you would be very happy if you did a common carotid artery during a clinical case. But this is absolutely worthless when it comes to doing an IMT measurement. Let's line it up to actually do an IMT measurement and see the difference. You see the difference in the interfaces, the sharpness? What we're looking for is basically a very sharp line. And you notice there's not much blurring in the near wall with this type of transducer. And what we want to appreciate is that full thickness and very sharp interfaces. And the positioning of the probe is very critical. It is right in the middle of the lumen of the artery in such a way that the near wall and the far wall are both visualized as clearly as possible. That's a very important technical aspect of doing this type of measurement. Now, there are protocols and different ways of doing it. One of the first large studies that was done was actually in the United States, sponsored by the NIH, NHLBI. It was called the Atherosclerosis Risks in Communities Study. It looked at individuals that are about 45 to 65 and see if they developed, or how, rather, what they had when it comes to atherosclerosis and what would happen to them if they were followed. And just, it's like an extension of the Framingham Heart Study. And there was another one a few years later called the Cardiovascular Health Study. Now, I worked on the Cardiovascular Health Study and got most of my experience doing ultrasound imaging and IMT at that point in time. Actually, I designed the protocol and some of the software that was used. Now, notice that, first of all, the probes that were used, higher frequency, you would say, should work better. Anybody who has experience with this ultrasound machine would know that it has poor near-wall imaging capacity. This alternative probe that we used basically had better imaging from a clinical point of view, although the frequency was lower. But it also had very nice near-wall and far-wall characteristics when it came to imaging. Another difference is the protocol. The ARIC protocol was a very rigid protocol where you had to measure the common between this location and this location, as shown here. And then you can only measure 0.5 millimeters going in that direction from the bulb. And the bulb was defined here retrograde from the level of the bifurcation of the artery. And then you measure the internal at this point. Now, we did a more simple clinical protocol where we said, well, we'll take a picture of the common carotid. We'll take 3 pictures of this area because that's where plaque is. And we want to have a picture of plaque. That's because we think plaque is very important. If it's important for high-grade stenosis, before the stenosis develops, it's probably important to see where it's at and try and measure it. The nice thing also is that more than one view is you get at least one of the 3 to show you the far wall or the near wall with some IMT measurements if there is no plaque present. So there's a little advantage. But the bottom line of using simplified protocols and a more traditional ultrasound probe and something that's clinically easy to use is the following. On top is the number of times we're able to do IMT measurements in CHS. On the bottom is the number of times they were able to obtain IMT measurements at the same locations in the ARIC study. And you see the difference in performance. Just able to get IMT measurements in a more consistent fashion with this protocol. Okay, so here we have IMT. We know how to do it. How do you validate it? Well, there's actually 2 major steps. There's 3 steps. First step is to make sure that if someone's got disease, the IMT parallels the disease. That is, if you have heart disease, we can see it in the IMT. even if you clinically have it already. The second is to see if you can predict future heart disease if you do an IMT measurement. And the third one is if you change something and IMT changes, it also is associated with a change in the outcome of the patient. Well, the first one is the association with someone. So you have a subject or a patient, an individual that has an ultrasound scan. You know you have a stroke. The question is, does that person have thicker walls? If that patient has coronary artery disease, defined as angina, for example, or having had a heart attack, are their common carotid artery walls thicker, yes or no? The answer is yes. If you look at their chance of having had a prior heart attack or chest pain, the thicker walls have a higher chance. That makes sense. Okay. Now, the real issue is predicting. So what you do here is you make sure, first of all, you get those people that we're considered normal. And what is normal? Normal is someone that comes to the doc and basically says, I'm fine. The doc does a physical exam and says, you're fine. I can find nothing wrong with you. Come back in a year. In this case, same thing was done, and they said, come back, and we'll keep track to see if you get into trouble. Basically, wait for you to get a heart attack or a stroke. And look back and see whether or not the IMT was predictive. And here are the results of the study, the CHS study. You can see that there's a progression of the likelihood of getting a heart attack or a stroke with the thicker wall. So this is the thinnest. If you take everybody, you split them into 5 groups. The smallest, the thinnest walls, the next thickest, and the thickest 20%. And you look at what happens to them. The people with the really thick walls get into real trouble over the next few years. Now, this is a thick IMT in the common carotid artery. Is that specific measurement linked to getting a future heart attack or a stroke? And here's the data for that. As the common carotid artery IMT increases, the chance of someone in the future getting a heart attack or a stroke increases. What about plaque? Well, the same thing. It's not exactly a linear effect, but you can see that it's definitely there. This is basically the rate, 5.6 per 1,000 person years versus 28. So almost a ratio of 5 to 1, 5 times more likely to get into trouble. That's a big difference. Now, the third point that I make is what happens if you change your atherosclerotic risk factors? And one of the strongest way to do that is to use a statin. A statin is, as you well know, is a lipid-lowering agent. And here's a study done in 1996 that basically shows that if you use ultrasound to monitor these patients and you give them statin, the people who get the statin, their walls stop to show increases in atherosclerosis. In fact, they decrease. The wall thickness decreases. That suggests that there's a linkage between cholesterol exposure and the thickness of those walls. Now, there are other studies that were done out there. One actually compares 2 different types of statins, atorvastatin versus simvastatin. The interesting thing about this study is that in order to really pick up a difference between the 2 drugs, they had to average the IMTs at the 3 location. If you only measured it in 1 location, it really didn't show that much of a change. But you had statistically to combine measurements at the 3 different levels to basically show that there was a strong difference between the 2 agents. Now, here's my favorite. This is where you can see, this is in the Wall Street Journal, equivalent of a blog. It says, what the heck is IMT? It was January 15, 2008, before a financial crisis. Merck and Schering-Plough, who were allied at that point, had a little financial crisis ahead of everybody else because they had invested in a trial where they were using 2 drugs, one to lower cholesterol, another one to interfere with the absorption and metabolism. And unfortunately for them, when they measured the IMT between the 2 groups, there was no difference. And because of that, they took a big stock hit. Their value declined by 30 to 40%. So nothing is as simple as it appears to be. But what are the frequently asked questions about IMT? How is it measured? Does ultrasound device matter? Does the cardiac cycle matter? How small of a difference can we measure? Well, let's explore that. Now, how is it measured? The papers I've discussed up till now, those kind of classic ones in the literature, these are hand-drawn measurements of IMT. There's no computer software. In most cases, these have been certified readers that have done IMT measurements day in and day out for 3 months. We actually pay them for 3 months just to practice before they start doing an IMT measurement. And there's associated with some software to make sure that we keep the measurements and we can check how good they're doing. And you can use an automatic edge detector if you want. That's basically the devices that a lot of manufacturers are trying to sell you. And here's an example. This is an edge detector we designed, 15 years ago? Here's a human reading, and here's the edge detected reading. There are subtle differences. If I play this back and forth, one of the differences that is noticeable is really in this area. If you look very carefully, the human reader really hugs the wall, but the edge detector goes above it a little bit. You see that difference? And that's a difference mathematically on the definition of what an edge is. An edge is a transition from a white spot to a black spot on an ultrasound image. The transition is not on the white spot. It's in between. So it should be the pixel above or the half pixel above. Now the software knows this, but the human reader systematically does something they're comfortable with. And in this case, this reader likes to hug the wall, which is different from the mathematical definition of an edge. So an edge detector should at least tend to overestimate the wall thickness as compared to a human reader. Now, does ultrasound device matter? Well, we did the study in IMT, in the multi-ethnic study of atherosclerosis. Also, the study is called MESA. You can find it if you Google it. And one of the things we had to do before is we wanted to make sure we bought a state-of-the-art ultrasound machine. So what do you do in a case like this? You bring the ultrasound machine and you scan a couple of volunteers and you see what the images look like. So we decided to evaluate 6 machines. And we took pictures of the same individual, and we had the same sonographer take the picture. The only difference was that the machine was different, and the apps person was making sure that the quality of the image was optimized for their device. And we told them what we wanted to see, sharp interfaces, good, etc. And then I decided to send these, this is around 2000, I decided to send these as little email attachments and ask people to grade them and tell me which one was the best of all these images. Now, does someone see something wrong with this slide? I said 6, right? How many images are there? 4. You're going to say, why are there 4 images? Well, the truth is, 2 of the image sets were so poor, it was not worth even trying. You couldn't see the interfaces properly. So of the 4, we sent this survey, and ultimately what happened, we got one machine that performed better, more consistently, and that's what we picked. I mean, there was no bias, there was no commercial, someone told me that manufacturer X has a better machine for this. Then listen to them, just measure them. By the way, this is the second time we did this. The first time we did it for CHS, that's why we picked the ultrasound probe. And by the way, we learned a very important lesson back then. We were testing 8 ultrasound machines. We put them in the same room, we connected them at the same time, and we blew the fuses in the hospital. And unfortunately for us, the ICU was right next door. So that was not very nice for a while. But you learn a lesson about this. So the power drain on these ultrasound machines is quite enormous. Now, does the cardiac cycle matter? I showed you a dynamic loop earlier where the changes in the wall, are they measurable? They are. This is a curve of the diameter, and this is a slightly different scale, thickness of the wall, the IMT. And you can see during systole, when the artery expands, the wall thins out a little bit. And during diastole, when the artery gets a little smaller, the wall thickens. Just simple conservation of mass. That's supposed to happen. It's like a balloon. The bigger the balloon, the thinner the wall. Now, remember we spoke about the resolution of the ultrasound machine, right? 0.1 to 0.2. This is 0.1 on this scale. This scale, this graph, shows one person remeasuring 10 images of the common carotid artery on a monthly interval. It's part of quality assurance, okay? Now, according to our definition, if the resolution is 0.1, the measurement should fall within about 0.1 millimeters. Well, let me show you what 0.01 millimeter is. You'll notice something, that a lot of the measurements, at least for an individual, out here, the outlier that has relatively thick IMT, most of the measurements are almost right on, okay? So this 0.1 millimeter is kind of a misconception about the fact that we can measure IMT. We can measure it less than 0.1, somewhere between 0.1 and 0.01. Now, is IMT an imaging test? Well, according to the prevention conference that was published in 2000, yes. It says persons at intermediate risk for cardiovascular disease, and by the way, the word intermediate risk means the following. They have what's called a profile. They have a certain level of blood pressure, cholesterol, diabetes or not diabetes, men versus women. These come in to calculate that. And they recommend here that they may want to use a carotid IMT. Again, another conference task force reports basically that patients at intermediate risk may benefit from some kind of non-invasive vascular screening. However, it can add incremental information. In experienced laboratories, this test can be done. The problem is, who has an experienced laboratory? And the problem is, there are very few of those around still to this date. So, what is an experienced laboratory? An imaging laboratory that can do drug trials and epidemiological research. It's good equipment. Strict adherence to protocols. Measurements have to be done in the same location, the same way, in a very consistent fashion. And you know the imaging position is critical. Most of these people, when they participate in one of these trials, are actually certified. They actually send images over, and people check them. Readers check them to make sure they're getting the right type of picture, the right quality, and then after they can do 10, depending on the trial, 5 or 10 sets of images, they can get certified. And most of this stuff is done using dedicated workstations. It's not done in the ultrasound machine. It's not done with the cursors. It's done in some systematic way so everything can be stored. Now, what they're trying to do, and these are basically a way of classifying people. The people who have a high risk for cardiovascular disease are no-brainers. You know they're at high risk. Their cholesterol is sky high. They have something really wrong with their blood pressure. They need to be treated anyway. People with low risk, the chances are of them getting into trouble are very low. But there's a lot of people, actually about 40 to 50% of the population falls in this middle group, the intermediate. They don't know what to do. They're not really high cholesterols. They really don't have high blood pressures. You're not quite sure what to do. So you'd like to use some kind of additional test to do that. And the idea would be to go from this configuration to something like this. We want to put people from the center more to the sides. And that's the idea of a screening test, at least in the way that they want to use IMT. Also, to be able to use, for example, carotid artery calcium. And here's an example, more recent literature, the SHAPE screening for heart attack prevention and education. The idea is to find a vulnerable patient, and the screening is recommended in individuals 45 to 75 for men, and women 55 to 75. And here's an example of what to do. It's a bit confusing, but the bottom line is coronary artery calcium or carotid intima media thickness, or the two criteria, the two tests that people are proposing. By the way, this is now being paid for in Texas. I'm not sure how they're doing it, but that's being paid for. It's part of the reimbursement scheme now to screen this way. So let me tell you why it's difficult to do this. And why people, there are two big papers that describe kind of a consensus meeting, but the consensus meetings papers miss out on some of the information that the epidemiological guys, people like me, kind of figured out. First of all, IMT gets bigger as you get older. That men or women, doesn't matter, gets bigger as you get older. That's the way it is. My IMT is bigger now than it was 10 years ago. That's the way it is. Secondly, men's IMT are bigger than women's IMTs for the same age. Just the way it is. African Americans have got thicker IMTs than Caucasians. Just the way it is. If you use an IMT edge detector, you're going to get a measurement. Well, it depends on the edge detector. You're going to get a measurement that's much different than if you use hand-drawn lines and processing. You can see how much these lines are different? So if you try and use this as a nomogram, you're all over the place. So all these factors have to be put in. Finally, what's the cost? How much could you be able to charge to do this? Now, I'm going to go through this relatively quickly because Well, because it's kind of complicated, it's better to kind of go. And this is an analysis that actually was done by the Society of Vascular Surgery, 2001, 2002. And the idea is to look at CPT codes 93880 and 93882 and compare them to a possible IMT protocol, just to give you perspective. So I indicated that it's important to measure the common, but it's also important to get the internal. So whatever protocol we decide on, we're going to measure both, right? Makes sense? Because you got information in both. So let's try and figure out how to do this. And by the way, I'm not the only one to say this. There's a consensus conference published originally in 2004, republished in 2006, that basically says it's important to look at IMT in the internal. Specifically, they use the number 1.5 millimeters as being important. Where they got that number, they don't say. They just kind of say, well, 1.5 looks cool, and that's it. It's okay, it's a good number. I'm not going to criticize it, but that's the way they got to it. Now, this is data from the SVS survey, total imaging time of a traditional Doppler ultrasound exam in minutes. And this is the proposed IMT, 7 minutes versus 42 minutes. By the way, I'm sure most of you do, the sonographers in the audience know that you can get your carotid exams done faster than that, right? I mean, your clinical ones probably take less time than that. I'm sure there are a couple, maybe you'll get up to 42, but okay. So at the most, the actual imaging time is going to be much shorter for IMT. And we haven't factored in the measurement process. Now, this is, again, data from the SVS survey, and this is basically, they have in-room prep time. Well, you're not going to change that. You still have to get the patients to sit down and calm down, get their heart rates down a little bit. You want to do the paperwork, that's still going to take you some while. Maybe a bit shorter, I don't know. I just put the same number. It could be 20 minutes because you don't have as many Doppler measurements to write all over the place. And signing the report, doing whatever. And these are actual times that are registered there. They're long. They look like very, very long. If you add them all up, the exam, a carotid exam adds up to more than an hour and a half, but that's what's published. So total time for the non-imaging component is 43 minutes. So you have 42 and 42. By the way, that's longer than the type of exam that I do. But the bottom line is this. You don't get away with this overhead. And the difference between the two examinations, officially, these are official numbers from surveys, the 85 minutes is what you'd expect to do for a traditional carotid versus something that's, 20 minutes, 30 minutes less for an IMT measurement. So it's something to keep in perspective, specifically if you try and figure out how many RVUs this is worth. And you get a number somewhere between 2 to 4 RVUs for doing the examination. Remember, an RVU is about $35, $36, depends on where you are in the country, which state you're in, and this is without the actual analysis. Okay, well, I need to give you more perspective before we finish up. You're going to say, what is this all about? The question is, does Dr. Pollack have a nail fetish? Maybe I do, but I will not admit to it in public. The reason why I'm showing this slide is to ask you a question. How thick is your nail? When you look at it on end, how thick is it? It's not very thick, is it? The actual number is 0.48 millimeters. You know what the average IMT of an individual that's about 60 years of age is? It's 0.67 millimeters. It's 50% larger. That's not a very big measurement. Try and look at your nail. You're measuring something that's about half as big as that. In most cases. In fact, in some cases, you're measuring something which is the same size. Interesting. That picture that you see on the screen doesn't look like your nail, does it? But that's what you're doing. And to give you a better perspective, this is that global length. That's about 0.6 millimeters or somewhat. This is a nail. This is a 10-year change in IMT, and this is a 1-year change in IMT for perspective. So look at what we're trying to do with ultrasound imaging. It's a little bit surprising, but that's actually what we're doing physical measurement-wise. And you know what? It's starting to work, which I don't understand, but that's the way it is. So bottom line, who could perform good, reliable IMT measurements? Well, I ask you, private physician offices, maybe. Especially if they use their secretaries to do the scan, right? It's going to work great. I'm being facetious. I'm being facetious. That's what I mean by non-sonographers. Measurements done on the screen of the ultrasound machine. Well, you know, now manufacturers say, my machine will do this, my machine will do that. You always ask the following question. Prove it to me. Where's your data? Is this measurement been used? Is there a study that used your measurement to do it? There are a few edge detector softwares that have done it, but they've not been connected to the machine. They've been offline, turns out. And here's an example of what you'd like to do. You'd like to do what we discussed. You'd like to say IMT versus age, and you'd like to split them up into different risks. I mean, I actually live somewhere, well, I won't tell you this axis. I live below this line a little bit, just a little bit below this line. I'm trying to keep myself there. If I see myself going above this line, well, that's going to be a different story. Statins, here you come. The CPT code, by the way, for IMT is 0126T, which is a non-reimbursable code. It's supposed to be reviewed this year, I believe. None of the computer software that I know about in the ultrasound scanners have been validated in the general population. They just speculate that they should work. So bottom line, I think I reviewed everything, give you perspective, so you realize, always remember when you do an IMT, your nail. That's what you're trying to measure. So CIMT is an imaging test. It can be done. It has in the right hands, you can see it's very consistent. It's been used for drug trials. It's been used to make major therapeutic decisions in the way that we've altered the medications that we use for cholesterol lowering. But despite this facet, the clinical side is still lagging, unfortunately. But we're going to get there in the near future. Okay, with that, I thank you very much for your attention.